anxiety in our society. So I thought this is a really timely topic because I'm going to be presenting evidence primarily from the human side, but I believe there's a lot that can translate to our animal patients. And so with that, I just wanted to introduce you to Julie. I may need you to give me power here to move my slides.
You should be able to, if you click to the side, to move them. Are you having trouble?
Let's see.
Yep, I see them moving.
Okay, there we go. Perfect. So the topic of translational medicine, which is a rapidly emerging area of medicine that is highly collaborative and multidisciplinary, is really taking bench-side research, so laboratory research that normally would take years to have a clinical impact, is really taking a more proactive approach and taking that bench-side research and applying it more immediately for a clinical application. And another word for this, when we think about borrowing information that we're gaining from the human side and applying it to veterinary medicine, is also One Health. So this is the notion that human physicians can work collaboratively with veterinarians in order for us to gain both ways, because veterinarians certainly can teach a lot to human physicians, as we're finding with coronavirus. We've all dealt with coronavirus in both dogs and cats, and we have a basic understanding about these diseases. And so it's a really interesting area where, if we think about the beginnings of specialty medicine and veterinary medicine, that's exactly what we were doing. And in fact, it goes back to my home. I work at the Animal Medical Center in New York City. And in fact, the hospital was open in the location that it is because we are in the near vicinity of world-renowned human hospitals. And before veterinary specialty existed, veterinarians at AMC who had a special interest in an area, let's say cardiology, they would train with the human cardiologist and then bring that knowledge and share it back with veterinarians. As the specialty colleges began to develop, we seem to have lost that connection of training directly with human physicians, because now veterinary specialists train veterinarians, and there's less of that interaction. And I would argue, particularly with what's happening in our world right now, that this One Health approach, this translational medicine, is really relevant. And it carries over into topics that you may not think are that relevant, like psychological conditions, for example. And I'm going to show you today how these approaches from the human side, particularly in how emotions can have an effect on pain, can translate to our human patients. And so I hope I can teach you some interesting approaches for our patients. So what we're going to be covering today is how mood can have an effect on pain. We'll talk about specifically the physiology and neurochemistry of how chronic pain, anxiety, and depression share a lot of the same neurocircuitry. It's really fascinating. We'll discuss how to recognize chronic states of stress and anxiety in our patients, and how we can use these translational methods from our human counterparts and apply that for reducing pain in our patients. And we'll end, of course, with some very practical applications of both pharmaceutical approaches and non-pharmaceutical approaches about how you can mitigate these emotional states to improve pain management in your patients. So with that, I wanted to start with our first interactive question. So what I want you to do on your cell phone is you're going to type a message to the phone number 22333. So you just open your text message and create a new.
Looks like you dropped off, Dr. Alvarez. Are you there?
Can everybody still hear me? Yep.
Now we can, but
Now
you
we
dropped
can.
off for quite a while.
Perfect. Okay, guys, so just again, type in, send a text message to 22333 and type in the message box NAVC26. That will activate your poll. And then your next message that you send, put in your answer, A, B, C, or D. So what factors affect pain perception? Do you think that the main factors that affect pain perception are genetics, the genetics of the patient, their current mood? Is it their history of anxiety or depression, or is it their environment? So it looks like we're starting to get some answers in. So this is all live. So as you put out your answers, we're going to start seeing people's responses here. So again, if you're having any difficulty on your cell phone, type into the phone number 22333. Your next message should be NAVC26, and then that will activate your polling, and then write your responses. What factors do you think affect pain perception? Is it genetics? Is it current mood? Is it a history of anxiety or depression, or the current environment of that patient? So I'm just going to give a few moments here. It looks like we're having quite a bit of participation here, which is awesome. I love this. Thank you for participating, everybody. So it looks like a lot of people think that genetics, so how you're born, so basically saying that doesn't really matter what your environment is like, it's what you're born with that's going to affect your pain perception. And that's certainly true. Genetics do play an important role. And then a lot of you, the majority of you, think that a patient's history of anxiety or depression is perhaps the biggest factor. So I'll tell you that you're all correct. There's a bit of a trick question here, because these are all correct. In fact, we know that a patient's pain perception is affected by their genetics, but also their current mood. What is happening in that moment affects their pain perception. Certainly, we'll be talking about that if a patient is prone to depression or anxiety, they tend to have higher levels of pain states, as reported certainly in the human literature, but also what's happening in the environment can increase your level of stress and then affect your pain perception. So what is the effect of mood on pain? Well, it's very interesting, I think, to think about, well, what is pain? What is the definition of pain? The International Association for the Study of Pain defines pain as an unpleasant, subjective feeling and emotional experience that is associated with an actual or potential tissue damage. So take a moment to just really absorb that. It's really, pain is all subjective, and it's actually your own emotional experience with what may or may not be causing actual tissue damage. And I think you can probably relate to this maybe when you were a child, or if you have a child and you go in for a vaccination, that child begins to experience pain before the injection even takes place. And it's because of your emotional experience. Your anxiety is riding high, and that actually upregulates your neurocircuitry, so that when the tissue damage actually occurs, your perception of that pain, your emotional and subjective feeling, is more heightened. So it's really interesting to think about pain. It's quite individual and is very much subjective and emotional experience. So I think that tells us a lot when we just think about what pain actually is. And that perception of pain is dependent on what we just talked about. It's definitely your genetics, it's your current emotional state, it's behavioral influences, your own psychological state, and environmental factors. These all play into that perception of pain. And what's very interesting is that there is a very well documented relationship between pain and depression. And we know that they co-exacerbate each other, so that when there is pain, you are more likely to experience depression. And if you experience depression, you are more likely to experience higher levels of pain. And this does lead to functional impairments as well. We know that in humans, approximately 20% of the human population suffers from chronic pain conditions. And very interestingly, humans who suffer from chronic pain are 3 times more likely to be diagnosed with an anxiety or depressive disorder. So that's huge, 3 times more likely. And in addition to that, we know that there is a co-occurrence of these conditions. So patients that experience depression and or patients that experience pain, we find that they co-occur, meaning that these two conditions happen simultaneously 30 to 50% of the time. So basically your risk factor is higher to become depressed if you're experiencing chronic pain, and vice versa. If you suffer from depression, you are 30 to 50% more likely to experience pain on a chronic basis. And in fact, studies with functional MRI demonstrated that a negative mood in that patient at that moment was more likely to result in higher pain levels at the time that that functional MRI was performed. So very interesting. So they're actually demonstrating in the brain in an immediate state that a person's mood leads immediately to a higher pain state. So how does this relate to us as veterinarians? Could this be true in our patients? And I think if you stop and start thinking about your patients that present to the clinic with a high level of anxiety, or even I think we less commonly diagnose depression, but we all know those patients. There's some patients that definitely present depressed. Or think about your patients that are presented in a lot of pain and chronic pain, and I define that as, greater than 3 months. Do you also see in those patients this co-occurring anxiety and depression in those patients? And I think if you start thinking about your patient base, like I think about specific breeds like the Greyhound, right? We always think about, Greyhounds post-operatively, how they'll just circle the drain. Are they in higher states of anxiety? Do they present to the hospital in a higher state of anxiety? And does that then lead to a worse outcome? So we'll be talking about this, but I just want to get your brain thinking and associating with patients that you've already seen, and whether, could this be true in our population? I think the answer is yes. So pain and mood disorders, the reason why I think this must be true in animals as well is they actually share almost the same neurocircuitry. So the same pathways that carry signals to the brain for pain are the same pathways that carry signals to the brain for fear and anxiety and depression. And how does that happen? So let's think about when an injury takes place, and this could be, let's say that it's a fracture. So that tissue damage takes place. Well, that will lead to release of inflammatory cytokines in the body. That will in turn lead to a pain trigger, right? So then those pathways get sent to the brain for a painful state being interpreted in the forebrain. And that actually will lead to anxiety. Just the recognition of your brain that there is pain taking place will upregulate the patient's level of anxiety. That will lead to worsening pain, which will then lead to worsening states of anxiety and now depression as well. And we know that alone, that state of depression and anxiety, will release inflammatory cytokines. And so in fact, anxiety and depression cause an inflammatory response in the brain. So this is a cyclical pathway that is taking place, all with the onset of a tissue injury, but not even necessarily. So again, even just a patient who's experiencing depression or anxiety, that will release inflammatory cytokines and lead to this vicious cycle that takes place. So what is the relationship between depression, anxiety, and pain? We know that on the human side, the most common physical and psychological symptoms that are presenting to primary care are pain and depression. That is the number one, well, respectively, pain followed by depression. These are the two most common symptoms that human physicians are presented with in primary care. And we know that these have an adverse reciprocal effect on quality of life, disability, and of course, very high level of healthcare costs because they are so prevalent. And there's several really nice high evidence levels of human studies demonstrating that pain and depression share similar neural pathways and brain processes. And just as we talked about in that vicious cycle, depression in and of itself, as well as anxiety, will release inflammatory cytokines, which leads to an upregulation of pain signals, which then leads to more intense pain perception by that patient. What does this mean practically? Knowing that there's this association. Well, we attend ground rounds every week. Actually, now they're virtual, but at the Hospital for Special Surgery, which is the #1 orthopedic hospital in the world. And that's actually how I learned about, really paying attention to emotion regulation, because on the human side, they have demonstrated that for orthopedic surgeries, taking in a questionnaire of the owners and what their level of anxiety and pain is has a prognostic factor on the outcome of the surgery, which I find fascinating. So there were actually 2 studies, which I have referenced here. The second one here is actually a systematic review and meta-analysis, so highest level of evidence, where they found that pain catastrophizing, which is an anxious preoccupation with pain. So essentially a tendency for that patient to amplify the significance of pain, and their inability to inhibit fear and thoughts of pain or be able to control one's experience of that pain. So that type of outlook, mental distress, and or history of depression was found to be correlated with much significantly higher levels of pain scores and disability, so decrease in function, to the point where the outcome of those surgeries was poor. And this was demonstrated in total knee arthroplasty, so total knee replacements, total hip replacements in patients with chronic low back pain. So there's a lot of emphasis being placed on this now in the human hospital setting, because you really want to screen out your patients who are experiencing high levels of anxiety or depression and essentially treat that before you consider taking them to surgery, because otherwise those patients are likely to have a worse surgical outcome. Another systematic review that evaluated chronic musculoskeletal pain. So this was in patients that were in a state of chronic pain for greater than 3 months and that had scores of at least a moderate to severe of depression. They found that in that population base, a patient's positive outlook of hope or optimism led to lower pain scores and lower disability, leading again to a better outcome for them. So this approach of self-efficacy, in other words, if you can somehow manage your own emotional state, your own emotional regulation to have a positive outlook with hope or optimism, is likely to lead to a better outcome for your state of pain and disability. So really, really fascinating information, which could be both, I think, optimistic or depressing, depending on how you look at it, because how do you manage, I think all of us experience anxiety and depression, particularly with what's happening in our world now. So how can we take control of that? So one question I want to ask you to see if you know the answer to this, and this is not going to be interactive, but I'll just leave you a moment to think about it. What do you think is the most hidden yet most prevalent disease that we deal with every day for patients that are presenting to us with illness? What is the underlying cause of that disease that is presenting to us? I'll tell you that when I'm in a live audience, people will say to me, like, oh, it's anxiety, it's stress. And yeah, the answer is stress. Stress is the most prevalent underlying cause for many disease states that present to us. And I'm sure that you can think of examples of that. Think about, for example, sterile idiopathic cystitis in cats, or feather picking in birds, or separation anxiety in dogs. These are all disease states that are related to an underlying level of stress. Also gastric ulcers, we see that in humans, but we also see that in dogs as well. And so it really is important that we think about managing stress and managing anxiety, because we know that if we do that, we likely can then have a positive impact on how our management of that disease and what the outcome of that disease treatment is going to turn out if we don't ignore the underlying cause, the stress, the anxiety of that patient. And so I don't want to bore you with too much detail here, but this is the reason why stress can have such a negative effect on disease outcome. So when we look at stress, it activates the hypothalamic pituitary axis, in which the hypothalamus then releases corticotropin releasing hormone, which in turn will activate ACTH, and this leads to increased levels of cortisol. A secondary component is the activation of sympathetic adrenal medullary system, which releases noradrenaline and adrenaline. And we know that noradrenaline is associated with sensitization and fear conditioning. So very important to what we're talking about here. And this upregulation of the hypothalamic pituitary axis increases glucagon and renin, leading to decreased insulin production and sensitivity, leading to increased blood glucose, increasing inflammation and suppression of hormones, leading to altered behavior. And in addition, that sympathoadrenal activation will cause an increase in heart rate, increase in blood viscosity, increased clotting, leading to increased blood pressure. So, clearly chronic or persistent states of stress will contribute to an overall suppressed immune system and increased susceptibility to diseases. So therefore, stress management, I would urge you to recognize as an important aspect of disease management for your patients. And here's just a pictorial about, how fear and anxiety has a direct effect in the brain. So, really think about the brain in three separate areas. We have our thinking brain, which is the forebrain. Then we have our emotional brain, which is controlled by the limbic system. In particular, the amygdala is a really important area that manages these emotions. And then there's the more primitive brain, which is your brain stem, which is less affected by states of emotion. But essentially, if our emotional brain is activated, let's say by some fearful event or some anxiety-inducing event, what will essentially happen is that this emotional brain will override our thinking brain, and then our actions are dependent on that limbic response. You can think about this in a clinical setting. All of us have been through this, where a patient presents in a very high state of fear and anxiety, and their owners will tell you, oh, they're so sweet, he would never bite you. But what happens is that at home, when their forebrain is activated, that dog is not going to bite you. But in a high state of fear and anxiety, they are reacting from entirely their limbic system, their emotional response, that amygdala, which is releasing inflammatory cytokines and leading to a heightened state of pain and anxiety, and they are more likely to bite you because they're not thinking. That thinking brain has been overrun by that emotional brain. And so how can we change that? How can we change in a clinical setting for that thinking brain to be back in charge and to not let that emotional brain be the primary decision maker? First, I think we need to recognize what the signs and symptoms of stress are. So here's a boxer. You can see the classic signs of fear and anxiety and stress in this dog. We see the pin-backed ears, dilated pupils. They can be lip smacking, panting, and salivating excessively. Some of them will even teeth chatter. Their posture will be low and kind of shifted backwards. They can be trembling, shaking, hiding. They can shed excessively. Really what we want is to change that into this kind of dog, which is how the dog is at home, where they're very relaxed and they're much more likely to allow you to perform a full exam and for you to be able to treat them more effectively. I just wanted to show you an example from our own ICU at the Animal Medical Center, and you can just see how busy it is here. I mean, each of these cages has critically ill patients. There's heat lamps on there. There's a lot of people in there. There's a lot of noise. There's bright lights. This dog here, I'm just going to play it for you so you can hear what this dog is going through. So there's a lot of beeping noises. There's people talking in the background. And, you know, you can see this dog is restless. He's not even sitting down. He has a small space to be in. He was overheating, which is why they had a fan on him. You know, this is clearly contributing to his stress. Obviously, the dog is already dealing with a lot of stress related to the primary disease. However, can we somehow reduce that level of stress and anxiety and have a positive effect then on their outcome of their disease treatment? Beyond just immediate anxiety and stress that could present in the clinic, you should also recognize chronic stress and chronic anxiety. This is now behavior that the owners are going to notice at home, not just in the clinic setting. This can be things like restlessness and an inability to relax, poor sleeping habits. They're up in the middle of the night, or they're sleeping excessively. It can go either way. They can be lethargic. Often they're less likely to initiate play or to want to participate in play that you initiate. Destructive behavior with compulsive and obsessive behaviors in particular. They can excessive self-grooming, tense postures and muscles. They can have a loss of appetite. Again, it can vary between being lethargic to being hyperactive, changes in urination and defecation where they're having accidents inside the house, GI disorder, so soft stools or diarrhea. You know, now we're really going into the realm of this is now happening chronically if you're noticing these changes at home. Okay, so how can we borrow information from our human counterparts with translational medicine and apply this to our patients? Well, this is how they're doing it on the human side. So essentially you wanna manage pain coinciding with stress reduction. And one approach to this is what's called antecedent-focused treatment. So that is avoiding the negative stimulation if at all possible. And so an example of this in our veterinary situation might be, for example, pre-medicating the patient. So you're anticipating that there's going to be a negative situation. Another example of this would be for a cat. You know, don't bring them near a barking dog. So you're really thinking ahead of time to avoid the negative situation if possible. Another approach is emotion regulation at the onset of the negative event. So if you can't avoid the negative situation, then you can take what's called a response-focused approach. And so this is really giving a positive reinforcement while that negative event is taking place to try to allow that patient to have a better emotion regulation through that negative event. And of course, using multimodal approaches is also going to be effective. So leaning on your pharmacologic agents as well as supplements, behavioral strategies, and environmental strategies, all used simultaneously, can be effective. And which brings me to really what I like to see as a true integrative approach. You know, I used to think that integrative medicine was just the combination of conventional medicine with complementary and alternative medicine, but I realized we were leaving out a very important third facet of integrative medicine, and that is that in addition to your conventional health approach, which might be like using pharmaceuticals, and your complementary and alternative methods, which might be using things like supplements, acupuncture, and rehabilitation, you need to not forget the patient's aspect and the patient-centered decision-making to really make it an integrative approach. And this is where lifestyle and behavioral therapies can really have a massive impact on successful outcome of your integrative approach to medicine. So don't forget to think about the patient and what their decision making might be in the situation, because that can lead to a lot of positive success. So here is our next interactive question that I have for you. So again, just take out your cell phone. It should already be activated. So now you can just write your answer A, B, C, or D, or E. So how often are you currently prescribing antidepressants or anxiolytics for pain management? So right now in your current clinical practice for patients that are presenting in a state of pain, how often are you prescribing an antidepressant or an anxiolytic as a means of managing their pain? So we're getting some good responses here. All right. I like this participation. I love it. Okay, so it looks like a lot of people are entering their responses right now. So you should just be able to enter A, B, C, D, E. All right, so it looks like a majority of you are either using it less than 25% of your patients that are presenting with pain, or never. And I agree. I think that at least from colleagues that I work with, and you know, I'm in a rehab only facility and we're very tuned into pain management, but I think this is not something we think about. It's not at the forefront. We're not often prescribing antidepressants or anxiolytics for pain management, but hopefully after today's webinar, you'll reconsider that, and particularly for your patients that exhibit signs of anxiety or depression. So here's how the human aspect, the human physicians are managing this co-exacerbated pain and mood disorders. So because we know that they share similar neuro pathways, thinking about the neurotransmitters that are involved in pain sensitization, so things like serotonin, norepinephrine, and glutamate, which is an excitatory neurotransmitter, we want to think about using drugs that help modify the effects of these neurotransmitters. So using drugs like serotonin, norepinephrine reuptake inhibitors, a drug like duloxetine, which is Cymbalta, or selective serotonin reuptake inhibitors like Paxil, paroxetine, or tricyclic antidepressants like amitriptyline for the management of comorbid pain and depression. Duloxetine in particular, which is Cymbalta, was shown in some really excellent, again, systematic level of evidence human studies that demonstrated that particularly elderly patients who were suffering from osteoarthritis and major depressive disorder, the antidepressant that was most effective at reducing their pain was duloxetine, which is Cymbalta. Another drug to consider is ketamine. This is now used on the human side to treat patients with chronic depression and chronic pain because it reduces their central sensitization, and it has a direct effect actually in improving their states of depression. So it helps both. It helps reduce chronic pain and central sensitization and helps reduce their depression. Cannabinoids, another emerging supplement that has demonstrated efficacy for reducing neuropathic pain and anxiety. Interestingly, opioids have been shown to lead to a worse outcome for both pain and depression. So when you have this comorbid states of depression and anxiety presenting together with pain, you should actually try to avoid opioids because they have been demonstrated to lead to a worse outcome for both pain and depression. How is it that antidepressants can be effective at improving chronic pain management? So again, think about using these drugs particularly for your patients that are presenting with high or heightened states of fear, anxiety, or depression. In the Kucinich paper that was published in 2013, this is a veterinary publication, there was a good section talking about tricyclic antidepressants. So this would be like amitriptyline, and how it can have analgesic effects. And that is because it has effects as a serotonin norepinephrine reuptake inhibition. It also acts as an NMDA antagonist. So this again decreases central sensitization. It also enhances GABA receptor activity and has direct anti-inflammatory effects. So again, amitriptyline is not just a drug for anxiety disorders. Think about it for your patients with chronic pain. While in many resources, amitriptyline is listed at 1 to 2 mg per kg BID. Kucinich argues that due to pharmacokinetic data that we have about amitriptyline, he suggests using a dose of 3 to 4 mg per kg BID. Also cannabinoids, again, for the reduction of anxiety, and because we know that it has effect on neuropathic pain, we have a couple of studies published on the pharmacokinetics of cannabinoids in the canine population. You begin at 1 to 2 mg per kg BID. However, it has been demonstrated to be safe and not toxic for doses up to 8 mg per kg. I usually start my patients at 2 mg per kg and then reduce them to 1 mg per kg as a maintenance. And how does this work? So cannabinoids have a direct effect on the endocannabinoid receptors in the brain and the periphery. We know that these endocannabinoid receptors are widely present in our body. That is why cannabinoids can be so effective therapeutically. They modulate neurotransmitters. There's 2 main subtypes. So there's the CBD1 receptor, which is prevalent systemically as well as in the brain, and CB2 receptors, which are more prevalent in the immune system. We know that cannabinoids act synergistically with opioids and alpha-2 agonists, and it can be particularly effective for managing chronic neuropathic and refractory pain. Perhaps anxiety. We don't have the evidence yet in veterinary medicine that it can help with anxiety, but we believe it likely does. Interestingly, actually, this news just came out yesterday, but in 2018, the DEA changed CBD from a Schedule 1 drug, which was very hard to prescribe, to Schedule 5 drug, which is the more lenient schedule. But now, as of yesterday, it is now a non-scheduled drug. Epidiolex, which is an FDA-approved CBD product for the treatment of epilepsy and refractory seizures in children, is now a non-scheduled drug. So really interesting about what the implications of that, what that might be for our CBD products for our veterinary patients. I will say that we do have some evidence on the canine literature from just 2 companies, Elivet and Applied Basic Sciences. The Applied Basic Sciences are studies coming out of Colorado, and Elivet out of Cornell. And we know from the pharmacokinetic studies that have been published, the half-life of CBD is about 4 hours. So you want to dose this twice daily. So for seizures, you'd use a 2 mg per kg dose, and for osteoarthritis, a 1 mg per kg dose. Although again, I often will start at the 2 mg per kg dose and then lower it to the 1 mg per kg dose. What about behavioral therapies? This has been demonstrated on the human side to be particularly effective for managing these pain states. So taking cognitive behavioral approaches have been shown to be effective for managing chronic pain in people. And it's the combined use of those cognitive behavioral therapies together with antidepressants that have demonstrated the greatest efficacy. In fact, a randomized controlled clinical trial of humans suffering from chronic pain demonstrated that when those patients were taking antidepressants and following a pain self-management program. So these are things that they were doing at home to help modulate their emotional states, led to a greater than 30% decrease in their pain states. And interestingly, also, a third of those patients had a greater than 50% reduction in the severity of their depression. So again, it has an effect on both. So it improves both your pain and your depression. And that decrease in their pain persisted for 12 months after these strategies were implemented. On the veterinary side, you can think about the fear-free approaches as effective. And really, I would argue, get your behaviorists or your trainers involved in these patients. If you recognize the state of pain or anxiety in your patients, don't forget about including your board certified behaviorist or your certified trainers to help these patients manage their anxiety level, because that may have a very powerful impact in reducing their pain states. I'll just show you a little bit of this video approach in humans about how they do this emotion regulation. It's basically controlled by your breathing. I won't play too much of this, but it's pretty cool. So this is virtual reality. So the person wears a headset, and it's a type of meditated virtual reality yoga. So that circle is a patient taking a breath. So patients that suffer from chronic pain go into this clinic, and so that's inhaling. I'm sorry, this is inhaling and then exhaling when the circle gets smaller. And depending on how they're breathing, it changes the image that they see. And this is therapy for these patients. So breathe in and breathe out. So just that little bit, it's just relaxing to watch that. You know, how can we apply that to veterinary patients? I'll share with you my thoughts on that. Specific to our veterinary patients, don't forget to use your non-pharmacologic pain management. So things like massage, acupuncture, rehabilitative techniques, and things like the Assisi loop, which lead to a non-pharmaceutical anti-inflammatory effect, can be very effective for chronic pain management that has a non-pharmaceutical approach. How can you reduce stress in your clinic? So that, again, an antecedent focused approach, preventing stress. So perhaps pre-medicating with gabapentin for cats, or pre-medicating with trazodone for your dogs that are exhibiting anxiety. Positive reinforcement is huge. So this would be, again, the response focused approach, where while that negative event is taking place, like let's say the exam, which might be anxiety inducing, can you feed them some peanut butter while they're getting that exam? Or can you have positive praise from the owner? Reducing environmental stress with noise reduction, dimming the lights, pheromones, having the owner present for the exam. All of these things can help to reduce stress in the clinic. Other anxiety reducing approaches, I'd like to think of yourself, envision yourself as the patient arriving in a foreign country where nobody speaks your language and hands are being put around you and you're being tied down, which what I would call is a no consent exam. I mean, I think your fear level would be high. And then if somebody even just touches you, you would jump. Again, your pain perception is going to be heightened in that high state of fear and anxiety. So using a gentle and soft approach with continuous touch can be very effective. Having the owner present can be helpful. Having a comfortable bed on the floor or an enclosed space or cat tree for your feline patients. For small dogs and cats, I will often perform the exam in the owner's arms to help reduce their anxiety. For your chronically ill, your chronic anxiety patients, I think about the 4 S's. So smell, sight, sound, and sensation. So, and I really think about stimulating pleasure. I often teach my residents, don't forget about your happiness therapy. Happiness therapy is, I think, really important. And again, addressing the underlying stress that might be behind a lot of these diseases that present to our clinics. So in dogs in particular, their olfactory system is so well developed. Think about bringing in smells that can be calming for that dog. So things like pheromones, or can it even be something special from home, like a t-shirt of their favorite person, or the hair of their buddy at home. That smell can really have a tremendous impact for our patients. Sight, taking them to their favorite places. Even if they've lost mobility, you can put them in a stroller and take them out to their favorite places. Sounds, play, even if they're not present, put them on the phone for sounds of familiar voices of people or other animals that they love. Playing classical music or other calming music. I'll give you some references for specific frequencies that have been shown to reduce stress and anxiety. And sensation, massage is a wonderful tool that you can teach owners to do at home to reduce stress and anxiety for your chronically ill patients. This is a patient of mine that lived to be 18. And as I said, even though she lost her mobility, the owner would take her out in her stroller to Central Park, where you could just see her eyes brighten up, and she was able to smell and take in all of that environment to help her feel better. So some of these resources would include Adaptable. So they have collars and sprays and things you can stick into the wall. iCalm actually has a blog and all sorts of resources. It's a free website. Healing frequencies you can play in your clinic or have owners play at home is a solfeggio frequency, which is 285 hertz. It's called the Miracle Note, or 432 hertz, which is called the Healing or Nature frequency, as well as 528 hertz, which is considered to be promoting DNA repair. You can type these into your favorite source of music, and you will find all sorts of playlists that you can download for free. Lick mats can be very nice in the clinic so that the dog is licking some peanut butter while you're examining them or doing that, unpleasant, exam or whatever you might need to do that might be negative for the dog. Wearing a thunder shirt, and the Assisi Calmer Canine is definitely something you want to consider to help reduce anxiety in your patients. And there's actually really nice evidence for the Assisi Calmer Canine. First of all, the signal is different than the TPMF, the Assisi loop, which I use for pain management. The Calmer Canine uses a different signal, which actually targets that amygdala, so that limbic system we talked about that is so important in generating emotion. That signal is been demonstrated to help reduce anxiety. And they did do a prospective open clinical trial out of NC State led by Margaret Gruen. This was presented at the International Veterinary Behavior Meeting in July of last year. They had 9 dogs with severe separation anxiety. They treated them for 50 minutes twice a day for 6 weeks. They had owners video these dogs at home at day, I'm sorry, that should have said day 0, not day 9, day 28 and day 42. They found that all 9 of these dogs had reduced anxiety scores at day 28 and day 42, and 5 of them actually had complete resolution of their signs by day 42. So pretty compelling evidence. They are now doing a larger closed center, so a blinded study to see what the results are with a higher number of patients, but pretty compelling results there.